Welcome, everyone. Thank you for joining us. I'm Lily Jelinas, Editor-in-Chief of American Nurse Today, the official journal of the American Nurses Association, and I'll be serving as your webinar moderator. Our topic today is the Analytics-Centric approach to improving staff morale and resource optimization, presented by two esteemed workforce experts. We thank them for their time and the valuable information they've assembled for us. We also thank our sponsors, Avantas and PennState Health. Now, let's discuss our plan for today. The presenters will describe the benefits of applying robust analytics and forecasting methodologies to nurse staffing and scheduling. They'll also highlight how nursing and other leaders can harness data to drive meaningful improvement using leading-edge data-driven decision-making tools. Your participation in this session will help you understand how applying these methodologies positively impacts your entire organization, staff, and patients. You'll learn how to enhance work-life balance and increase morale for managers and staff, improve the patient experience through optimized staffing, uncover specific savings initiatives to avoid non-strategic cost-cutting mandates, and reduce manager scheduling burden by empowering them to be more proactive and tactical with resource planning. Now let's meet our panel. Our presenters for today will be Ms. Jackie Larson and Mr. James Fanouche. Jackie Larson is the president of Avantas, a healthcare consulting company that offers predictive analytics, operational guidance, and scheduling technology. Ms. Larson is a healthcare industry veteran and a recognized thought leader. She joined Avantas in 2008 and has been the driving force behind building the company's client management, analytics, and consulting groups into world-class teams. She provides guidance and expertise on a wide range of issues including workforce optimization, productivity enhancement, labor pool development and incentives, system integration, resource management, and business analytics. James Fanouche, Jr. is the Vice President of Nursing Clinical Support Services at PennState Health's Milton S. Hershey Medical Center, a twice-designated magnet hospital and the only medical facility in Pennsylvania to be accredited as both an adult and a pediatric Level 1 trauma center. In addition to his work as a nurse and administrator, Mr. Fanouche is also an author and speaker on numerous topics related to nursing and healthcare workplaces. Now, please welcome our first speaker.
Thank you for joining Jim and I today. So we're all familiar with the pains of workforce management in healthcare. This chart might look familiar to many of you. This is the chart from the U.S. Bureau of Labor Statistics, and it shows us the difference between job hires, which is the bottom white line, and job openings, which is the green rising line. The critical spread is the gap of unfilled healthcare jobs. So I'm sure many of you on the phone are feeling this increasing gap on a daily basis. What we saw was 2 years ago, approximately 30% of healthcare jobs went unfilled. In 2016, the percentage of unfilled healthcare jobs rose to 50%. Today, there's over 600,000 unfilled jobs in healthcare. Nursing is the single biggest healthcare profession, so it stands to reason that many of those unfilled jobs are nursing positions. And frankly, we don't see that trend changing anytime soon. We believe that providers need to maximize their sourcing capabilities, but they have to do much more than that. They need to workforce optimization that leverages and uses the staff that they have in the most optimal way. And if the punch in the face wasn't bad enough, we did a survey back in 2016. 94% of nurse managers surveyed stated that staffing has a negative impact on morale. And nurses said that it makes them feel that nobody cares about how hard they work. As morale continues to decline, so does the increases in call-ins and absences, which you can imagine that stretches staff even worse. So what's the next step step that usually occurs. Staff leave. And I call this the infinite loop. So the cycle begins again with an even deeper staffing deficit, which leads to poor morale, which increases call-ins, followed by turnover. So you all get the idea. So Jim, if you would, could you talk to us about how scheduling and staffing issues impact the patient side of the equation?
Sure. Thank you, Jackie. So as all of us as healthcare executives are focused on how to increase patient safety, patient quality, and become high reliability organizations, I think it's important that we sit back and really look at the fact that if you don't have the right number of staff to care for your patients, it becomes very difficult to deliver high quality patient care. And so, we really focus very heavily on ensuring that we have that right mix of staff being able to care for the patient at the right time, and have that be a predominant focus for our nurse managers on the front lines to make sure that those staff are there to care for the patients. If you don't have the right mix of staff, that then does lead to quality impacts on the backside, and none of us want to have to deal with that. So, using predictive analytics and forecasting tools, we're able to really proactively look at that to ensure that we have the right staffing mix at our organization.
Thanks, Jim. There's good news here. There's absolutely solutions that can help with these challenges. In fact, they've been used in other industries for years. So predictive analytics offers a new approach to scheduling and staffing in the healthcare industry. Interestingly, the same study that I referred to earlier, we found that 80% of nurse managers didn't even know that scheduling technology existed, and particularly scheduling technology that embedded predictive analytics. Let me walk through a quick example of how all that works. So the first thing we do is we collect big data, and that can be patient census. It can be business information about the enterprise itself. It can be local or regional information that can impact volume. We then process that data through sophisticated mathematical modeling that incorporates all of the multiple variables. And then we create exploratory models that are created both before and after deployment to refine the modeling, ensuring that we have the highest accuracy possible. So the overall process of predicting staffing can occur 120 days in advance of the shift with this type of methodology. The good news about this is with this technology, we can predict within one staff member 2 to 3 months in advance of that shift, with accuracy going as high as 98% 30 days out. Without an accurate projection of staffing needs, what we see, and you all probably witness this, and some of you may feel it yourself, managers are spending hours every week struggling to fill those open shifts due to call-ins or just being short-staffed. And typically, there's this chaos that ensues 2 hours before the start of the shift, trying to get people to come in, offering high incentive rates, because they just want to make sure that they get the staff in the door to care for those patients. Jim, I want to turn it over to you and ask you to describe how predictive analytics has helped you at Penn State Health.
Sure. So, we really focus on labor management at its highest level and use those foundational evidence-based research tools to help us. And then the predictive analytics sort of is icing on the cake, because it really provides us value to allow us to forecast and then have the appropriate contingency resources available to us. So we are able to better right-size our float pool. we are able to use our staffing software, SmartSquare, and then those predictive analytics are actually baked into our software staffing models, so that when nurses begin to self-schedule for a particular period of time, they actually are scheduling based on the needs of what the predictive analytics are telling us. So in a real-life example, in our surgical ICU, it may tell us that on July 18th that we're going to need 25 nurses. On July 19th, we're going to need 22 nurses. And on July 21st, we're going to need 26 nurses. And so that allows us to be able to appropriately build those models, because we're scheduling about 6 weeks in advance. And so, historically what happened was we weren't able to staff to a particular number. And so, we would staff across the board, and it would always be, say, 22 in my example in the surgical ICU. And some days we would fall short of that, and some days we would not have, or we would have an overstaffing. And so predictive analytics has provided us the ability to staff to ensure that we have the right caregiver or nurse at the bedside to meet that patient demand. So additionally, Jackie, we are leveraging our quality of work life council through shared governance in nursing. And through using these predictive analytics, we have worked with that council to demonstrate our nurse vacancy rate, looking at our average daily census, looking at the percent of RN fill rate, looking at our core and contingency staffing ratios, the number of hours in which a charge nurse must be assigned and taking patients, and we've also worked with them to look at incidental work time. And so all of those have really allowed us to provide a lot of transparency to our frontline clinical nurses and partner with them to make sure that we are staffing to meet the needs of our patients and our organization. And so in addition to that, we are also using a fairly simplistic forecasting tool. So this is different than the predictive model. So the forecasting tool is a simple Excel spreadsheet that evaluates FTE changes over a 12-week period, looking at several data elements, as you can see on the screen: projected staff vacancies, turnover, leave of absences, and retirements. And then these elements are evaluated against staff hires, staff completing orientation, and staff returning from leaves of absences. This actually then enables our nurse leaders to have a proactive conversation with nurses about their staff and about future personal plans that may impact our schedule. These practical tools then allow our nurse leaders and clinical nurses who are on scheduling teams to really actively participate in staffing strategies, and those overall strategies have resulted in about a 97% accuracy of staffing here at Penn State Hershey. And what we found is, through using these simple forecasting tools and the predictive analytics software through SmartSquare, we've created the ability to fill 95% of our staffing needs and really be proactive and develop a cogent staffing plan. And it also allows us the ability to recruit those contingent staffing resources in advance. So many of you can resonate with the fact that you may need to use RN travelers within your organization, and this tool allows you to predict or forecast, if you will, where those resources will be needed and when you might need to order them. And so it allows you to be in advance of when everyone else is sort of doing it.
Lots of great information. I'm sure you'll agree. We have several questions that are coming into our webinar now, so let's begin with those now. Jim, for you, the first question: in addition to predictive analytics, what other tools can organizations use in order to optimize staff?
Yeah, I think one of the important tools is really looking at your registered nurse fill rate and determining what that looks like compared to your budget. So, looking at those tools, whether it be in Smart Square, there is an RN fill rate report, but really looking at how are you compared to, if you were staffed to provide, 15,000 hours for a particular month for a nursing unit, what did you actually provide? And, really looking at trends, and those sorts of reports and tools can help you tremendously in terms of making sure that you're optimizing staffing at your organization. I think the other tool that is helpful is, many staff are concerned about whether or not a charge nurse, as an example, has an assignment, and do they have patients, and are they commingled with an assignment. And so looking at data around those particular metrics, I think, are also helpful, because then it showcases for staff that you're focused on not only having the right mix for your patient volumes, but also focused on them as a healthy work environment strategy to make sure that we're meeting their needs as a frontline staff member.
Absolutely, because if they're assigned as a charge nurse, but they're actually working as staff, they're not doing what the charge nurse really needs to be doing, making sure the patient experience is what it is, assuring a healthy work environment, and assuring patient-safe care. So when you say there's lots of room for making sure that that role is very, very focused, the charge nurse role?
Yes. Yeah, the other tool I'd like to sort of showcase as well is, really looking at your where your staffing sources are coming from. So looking at reports that tell you that say, 85% of your staff came from your home core unit, 15% of your staff came from contingent resources, and then a breakdown of what does that contingent resource actually look like. Did it come from your float pool? Did it come from your per diem pool? Did it come from staff in the core unit doing overtime? Did it come from a traveler resource, as an example? So, that again helps you determine, do you have the right skill mix and the right level of resources and layers within your home organization.
Perfect. Thank you so much. Jackie, there's a question that has come in for you. You mentioned during your presentation a statistic about the accuracy of predictive analytics. Can you talk a little bit more about that? Where did you get that stat?
Yeah, you bet, Lily. So that statistic was specific to the Avantas predictive model, which is embedded in our scheduling tool, Smart Square. We actually took a study just this year, that looked at more than 25 million shifts across 17 hospitals over about a 6-month time period. And what we discovered was that 60 days out from the shift, forecasted need was within one staff member of what was needed 96% of the time. So as you can imagine, being able to predict well in advance of the shift creates a very positive paradigm shift for those units, hospitals, and systems that have access to this type of predictive analytics.
That's outstanding, and I bet chief financial officers would like that as well. In addition to the technology that we've mentioned, what other strategies should hospitals and other organizations be looking at?
Yeah, that's a great question. It's really easy to look at technology as the answer to everything, but the truth is that any technology is just a tool, so you need to have the right strategies in place, the right people to carry out those strategies. We look at things like operational alignment, making sure policies are followed in alignment with every area across the organization. We also talk a lot about centralized resource management as well as float pool development. These strategies are managed and automated by technology, but they really need to be rooted in proven best practices.
Absolutely. Thank you. Jim, I'm
Yeah.
going to come back to you, and this is really a great question. As a nurse executive, I'm dying to know your answer to this one. How do you factor in patient acuity, which is, of course, variable and not necessarily predictable?
Yeah, so Lily, that's a great question. What we actually do is, as you know, as a nurse executive, you really base your budget on trying to forecast or predict what your volumes are going to look like for the year. And then, in building those budgeted staffing models, we really try to account for, in the budgeting process, for example, on one of our acute med-surg units, we care for post-op kidney transplants. And so we bake into the budget that we're planning for, as an example, 100 transplants to occur during the course of that year. And of course, as with anything, these are all based on averages. And so, but at least it helps create a stronger and more robust budget up front. And so then, when it comes to day of staffing, that's where we really leverage our contingent resources at Penn State Health. So we have in our software scheduling tool, we have a feed that comes directly from our electronic health record, and we look at staffing volumes 5 times a day. And with those staffing volumes, then we are able to make real-time adjustments based on acuity or skill mix or other factors that we believe are important. And so our centralized staffing resource center, our off-shift house managers are really working with those frontline charge nurses and saying, okay, so I see that you have 25 patients that are going to be on your unit today. Is that number really accurate? And they'll say, well, actually, no, we have a couple of patients who are going to the OR. We have a few discharges that are happening. I'm concerned about the high number of isolation patients on our unit. And so at that point, we're able to then put an adjustment into SmartSquare and deploy additional resources to assist them. In some situations, that acuity and skill mix, which of course isn't predictable, as you point out, is in the opposite direction where, we don't really need to have 14 nurses on this unit today. And so that's where we're able to then float those nurses to another unit who have that increase in acuity and skill mix. I think the other piece is, we've been fairly innovative over the past couple of years. We put in the role of the nurse resource coordinator, and that individual is actually, there are 2 individuals around the clock who essentially are available throughout our organization to deal with bursts of clinical activity, assisting units with a crisis like a code, a rapid response, a brain attack. And so those individuals are also another resource, if you will, to allow us to assist when, there's an increase in workload. So we've tried to focus pretty heavily here on not having a patient acuity system, and we've actually found that it really has been to our advantage. The SmartSquare staffing tool through Avantas has really provided us everything we need by really looking at those workloads and providing those adjustments in the system.
So just tell me if I'm being accurate in having heard you too, the tools that you use help your nurse leaders focus on attaining an RN fill rate of 95%, right? That 95%
Yes.
mark. So it would seem that if you are primarily always at the 95% staffing mark, you're in an excellent place in order to deal with those bursts, as you say, or patient acuity, or nurse competency variation. If you have an entire shift of nurses that maybe are new, are not as experienced, because you have that stable level of staffing at the 95% level, your contingent staff are the ones that are able to fill in variation gaps. Is that correct?
Yeah, it is. I think so. I don't want to misguide our listeners today. I mean, so 95% is what we strive for. There are certain units across the year that are lower than that number, and that's where we're always looking at trends and data to say, how do we fix this area? Do we need to get additional contingent resources in? And one of the other things in our particular situation, similar to other organizations around the country, is we run at a capacity of greater than 100% almost every day. It is predominantly on weekends when we end up feeling some relief, but it is nothing for us to be at 105, 110% occupancy. And so that's where some of this becomes a bit more challenging. Even though we have the right staffing mix for the budgeted patient days we have, when we're over our volumes, we are feeling a deficit. So, in this particular last quarter, if you will, we're running about 5% over volume, and so we're feeling that in terms of being able to provide the right mix of resources to our units.
A clear dose of reality for us all, for sure. And so, since you mentioned it, I'll stick with you for just a moment with this question around vacancy and turnover. All of us are challenged with it. Some parts of the country with very large vacancy rates, depending on whether they've got schools of nursing in their market or not, et cetera. So what's Penn State Health's experience? Is it any different because of the use of predictive analytics?
Yeah, so our our organizational turnover rate for last year, if you will, was sitting around 8%. That is clearly lower than the national average for turnover. I mean, the national average in calendar year 16 was sitting around 16% nationally. So clearly, that was for all hospital turnover. That's the national stat, and then the RN turnover is around 14%. So we're clearly lower than the national average. Our vacancy rate is right around 5%, but that coupled with a census that is over the budget really puts us closer. So I told you we're about 5% over our budgeted targets from patient day perspective. So that puts us closer to a 10% vacancy rate when you think about it, because you have to add the two together. So, that's where the challenge comes in on, day-to-day staffing and making sure we have the right mix.
Sure, absolutely.
But, to your point, Lily, I think I was going to say using these, using the Avantas Predictive Analytics and, our homegrown simple forecasting tool has really positioned us well. And, I think we have, our turnover rates and vacancy rates sort of showcase that piece.
So, Jackie, for you, we hear Jim's organization's experience. You have such a broad experience with healthcare organizations all over the country, and you mentioned your advanced labor management strategy expertise. So I'm going to assume that the experience of Penn State Health with predictive analytics you're also seeing in other organizations across the country. It's a fairly consistent outcome of using these types of tools and technologies. Is that correct?
That is. I mean, it's a great observation, Lily. And the really nice thing is that while Jim and the team at Penn State Health has had tremendous success by embedding the right practices, utilizing the right individuals, having key executive leadership within those organizations that help sponsor labor optimization and workforce optimization as a primary initiative. From our client base, it is not unusual for these organizations to experience savings of 4 to 7% of total labor spend, which is significant, without reducing quality, in fact, quite the opposite, but also increasing employee satisfaction or clinician satisfaction.
Great, thank you. We are out of time, and so I'd like to thank Jim and Jackie for their outstanding presentations. If you'd like to read more, the November edition of American Nurse Today features an article written by Jim and Rita Berry called Predictive Analytics Empower Nurses. Quality care requires robust staff scheduling tools. So perhaps you'll be interested in reading more in the November edition of American Nurse Today. If we were unable to get to your question, our contact name and email is now posted on the screen, so feel free to reach out to us with your questions. For all of us at American Nurse Today, Avantas, and PennState Health, thank you for joining us. Have a good day.